Good afternoon. My name is Monica Oxford. I'm from the University of Washington. I'm the director of the Barnard Center for Infant Mental Health and Development. And today I'm going to talk about 2 randomized clinical trials in child welfare with children aged birth to 3. And the trials are on a program called Promoting First Relationships program. It's a 10-week intervention study, but it's a relationship-based practice. So our focus is to support the parent-child relationship, to help the parent enter the mind of the child, increase their reflective capacity, and their ability to meet their child's social and emotional needs, which in infancy is to feel safe, secure, and protected. It's an evidence-based program. It's also a training program. So we're training social work providers, bachelor's and MSW level, to do their service differently, to focus on the relationship. It engages developmental psychopathology and attachment perspectives. It's delivered 10 weeks, 1 hour a week approximately. We use videotape feedback. So 1 week we'll record the parent-child playing together, the next week we'll play it back. And we'll engage in strengths-based model with them where we're asking them reflective questions. There's also elements of homework and different exercises that we do with families. Basically, we're providing new tools for social workers to engage around the relationship. How do they engage around the relationship? So it's a training program. We give, providers are trained to use specific feedback strategies. So reflective questions, strengths-based positive feedback, and instructive feedback. This shifts their practice, and I'm going to show you a graph in a minute how it shifts practice. But parents rate this, 87% of parents in Child Protective Services rate this as highly satisfactory. 93%, once they have 1 appointment, finish the program, so there's very low attrition. And 95% would recommend it to their family. But this is a graph showing the MSW's pre-training and post-training. We recorded them and we coded their practice for reflection and strengths-based feedback, which was non-existent at pre-training. At post-training, those strategies increased dramatically, and that's a publication that you can get your hands on and look at the different satisfaction. This is a quote from, and you're not going to be able to read it, from an American Indian mom who's young and really talked about the importance of using video feedback as a way to understand and get into the mind of her child. And that's what relationship-based practice is. It's how do I get into the mind of my child? I'm going to talk about the main effects of 2 randomized clinical trials. So we have several randomized clinical trials, 3 in child welfare. 2 of them are already published. One is in Child Protective Services, the other one in foster care. We have 2 with American Indian families on reservations, 1 with Latina mothers who have a mental illness diagnosis and have just given birth to their child, early Head Start, and children at risk for autism. The results of the first 2 trials in Child Protective Services and family and foster families, I'm going to reference here. FFP is the foster family study. SPP is the CPS study. Over 200 families were recruited in each study. They were randomly assigned to the 10-week program or to a control condition. Children on average were about 18 months of age, so they were recruited if they were 1 to 3 years of age. I guess I'll just advance. The results of the first, let's see. Okay, so we improved parent sensitivity. We video record parents and children playing together and doing teaching tasks, and we have it coded by a blind coder. This is the core of the relationship. So we have improved parent sensitivity. We also improved parents' knowledge of child development. We improved child's affective or emotional communication and other competencies that can be measured in young children. This is the results of the reduction in child welfare foster care placements for those in the CPS study. This is 15 months post-treatment, so if they received PFR, they were 2.5 times less likely to be removed from their parents' care. In the foster family study, we improved the caregiver's likelihood of adopting or taking the child adopting the child into their own family if they received PFR. And we think the function was that they really understood this child. That's the feedback we get. They have a new commitment and connection to this baby in a way that they didn't before. So they're more likely to go on to adopt and the child to get discharged to a PFR, a parent who's received PFR. We also do better in challenging contexts. So we have stronger effect sizes for families in reunified birth families. If they receive it, their effect sizes are 2 to 3 times that of other samples. Larger effect sizes if the parent themselves were physically abused as a child. And for children who've had multiple placements, we have larger effect sizes for them. We have little sub-studies that we've looked at stress physiology because their babies are pre-verbal. This is a good measurement, very objective measurement. Respiratory sinus arrhythmia, EKG, EEG, and cortisol results. So for children at risk for autism, they were given different tasks, social, and that's the EEG study, social and face, or social and object appearance, and children whose parents had PFR had more social, more normative social engagement than object engagement. Let me go back real quick. In Child Protective Services with the EKG study, they had better emotional regulation, and in the foster care study, more normalized simulated cortisol results. If you have any questions, you can email me. Thanks.